Sure, it may mimic what your mother went through, but it's a really individual experience. Never mind the social embarrassment, time away from work because of menopause.
They're completely missing the signs. We tend to think it's later in life.
Maybe you're going into menopause prematurely.
If you don't care about women's well-being, you might care about the economy.
These are the patients that really benefit the most from vaginal estrogen, and there are so few reasons we can't prescribe that to our patients.
It is easier to ask for painkillers than something our body produces.
Today I have a very special guest. She has so many credentials. I'm not even going to try to list them all out. I'm going to give her the honor of doing it. But she is medically trained, and we cannot talk enough about what perimenopause and midlife is and about some of the misconceptions around how we can get support through this very important stage of life. So today I welcome Dr. Alida Pokoradi.
Thank you so much for having me. I'm really especially
Super
here.
excited. Why don't you tell us your story, your training?
For sure. So I was born and raised in Ancaster, just outside of Hamilton. I went to the University of Toronto for my undergraduate degree, and then I wanted to mix things up. I went to the University of Aberdeen in Scotland and did my master's and my PhD there. And now I'm a GYN oncologist, and I work at the Royal Victoria in Barrie. And then I just finished my 2-year GYN Oncology fellowship at the Gervais Hospital in Hamilton.
Okay, I feel out of breath just hearing you list out all your studies. So who better to ask than you? What would you say to people who think that menopause is being blown out of proportion? Like, why should we care about recognizing the signs of perimenopause?
Yeah, I feel like that's something that's very deeply rooted in misogyny. And as a gynecologist, and especially as a GYN oncologist, I feel like I deal with very marginalized populations, very vulnerable populations, just in my day-to-day. That's who I deal with. And it's patients who weren't listened to, that they said, I had these symptoms, and we're kind of taught, like, this is just how this is. Like, you are just bloated because you're female, or you pee a lot because you're female. And it's like, but sometimes there's like a next step that needs to be done. Even if it is for just kind of emotional security, that, yeah, things are fine. I also recognize maybe that goes at odds with what I was just saying in healthcare spending. But I think sometimes you just have to kind of put things in perspective. Really listening to the patients is critical. I think there's a lot of potential emotional distress. There's financial losses. Like, I'm not totally familiar with the studies, but some people have looked a lot into like time away from work because of menopause.
Absolutely.
And never mind the social embarrassment. So one of my colleagues at my, when I was doing my PhD, Dr. Ona Duffy, she has 2 PhDs. And her first was all about bothersome symptoms of the menopause in Scotland. And it was just very eye-opening. Just these patients are having to go about as if nothing is happening and continue their day-to-day life, because if they don't, there's the financial loss that comes along with it. And I can't remember Ona's study in and out. It's absolutely published for anybody that's wanting to read it. But I think if we made the corollary where someone's having like almost a heart attack, or someone has symptoms of their like active cancer, you'd be like, why are you at work?
Yes.
Or like, what can we do better to support you right now so that we can accommodate you in this time of your life? And also, do you need help? There's like a few times that we should be checking in with each other.
Absolutely. We'll put some references in the episode description for the publication you just mentioned. And I also know the Menopause Foundation of Canada just released a study with respect to menopause in the workplace, and as did the Mayo Clinic. And work absenteeism is real. The impact on women is absolutely real. And if you don't care about women's well-being, you might care about the economy, if that's the argument that's going to get you.
Yes. Money talks.
Money talks. Questions around the Women's Health Initiative. We've asked all our medical guests who've come on the show their perspective. I think the fact that you've gone deep into the menopause space, I'd love to hear your perspective on why it's still so much fear around menopause, hormone therapy, estrogen in particular, and menopause.
Yeah. The Women's Health Initiative was trying to achieve something great. It was published in 2002, 21 years ago, and it had an amazing following for a long time, but we realized it was actually a really poorly designed study. Despite it being huge, it included the wrong kinds of patients, all the wrong kinds of times to initiate these hormones, and unsurprisingly had some pretty big fallout, and has gone on to really color OBGYN residency, people's family doctor training about comfort with prescribing hormone therapy, kind of used as a really broad catch-all phrase at the perimenopause, menopause, postmenopause eras of people's lives. And unfortunately, it's something that's really hard to backpedal and overcome, because there's been this kind of 21 years of mistrust where we recognize, even when we kind of parcel out the data, look at the right age groups who was included, and we see that actually there's very minimal risk with appropriate use of these hormones. It's still really hard to overcome kind of the mistrust that the WHI really had a great job of doing.
And hopefully with more conversation and sharing some more recent studies, like, do you want to enlighten us on what we do know? You talked about the right group, the right time. So help us understand what we know now.
So now we know it's like, ideally, well, yeah, let's recognize what is perimenopause. Maybe we'll empower people that as long as you've lived long enough, and we're so fortunate to be here, it's like you will go through the menopause. It's going to happen. What it looks like, sure, it may mimic what your mother went through, if that was something that you and she ever discussed, or it may not. And there are so many factors between everybody's different lives that it's a really individual experience. And there's so many things that people need to be okay to speak with their primary care provider, if it's a nurse practitioner, whomever, or to be referred for extra help, where we recognize there's a few things that can be optimized. As far as like, okay, then when is it time to actually start about hormones? And what kind of hormones? I think we speak about things as such a broad topic. And I think everybody equates that the ones you take by mouth or the patch or like a topical are the same as anything that you're using locally. And very unfortunately, the ones that are local, like what I mean is vulvovaginal use, all of the warnings are the same that are the systemic ones. So these patients really get scared off when it could be excellent quality of life, are really dealing with some troubling symptoms that may have real like emotional fallout, even like physical fallout. So just really, there's a few moments where we need to kind of step back, realize what's important for the patient in front of us, and also educate as to like, okay, that's what's going on. And this is extra things you could anticipate, because I think there just needs to be, we need to bring menopause to the patient. It's like we do a lot of like preventive care for diabetes, for blood pressure, for cholesterol, all these things that I don't even know that family doctors have to know. But like, and how many people will be diagnosed with that versus anybody in Canada, like accounting for, maybe genetic variations, ethnicities. It's like the average age is 51.
Like, there isn't really any proactive, I've certainly not aware, and some of our guests who've, we like to call it the sisterhood. We invite guests going through it or perhaps on the edge of it. Is there a proactive screening, so to speak, or questionnaire?
Yeah, nothing that I personally know of, and nothing that it would need to be validated in like a wide group of patients, that it's appropriate, that we're actually capturing the data that's important, to be able to flag like, okay, it's time to like talk about initiating systemic treatment, or are we talking about bone health, cardiovascular health? There's a lot of things that I imagine are a lot of preventative screening tools that could probably be all integrated, just more geared towards like a assigned female at birth stance.
So what's stopping us from doing that?
Great question. I have a feeling finances is a huge one. In my day-to-day activities, there are so many things where I see the limitations of OHIP. I still think it's an awesome system that we work within, but there will never be infinite money. I think it's going to arise probably from, if it's the North American Menopause Society, or whether it's the Canadian OBGYN Society, the American equivalent, But I think we have to come together and recognize we have an aging population. That's amazing. We want people to survive and thrive. We don't want to be saddling people with illnesses that maybe we could have prevented or kind of captured at an earlier time point. Menopause is one of these things.
I want to go back because you gave us a ton of information when you were talking about the Women's Health Initiative. And we do say hormone therapy as a catch-all. Are there different types of hormone therapies based on your stage of menopause?
Yes. So the 51-year-old split being basically until you're 51, probably you'll have basically the premenopausal, what we call milieu. I am not francophone, butchered that word. But the mix basically of hormones where your body is expecting some estrogen. It's absolutely essential. So the patients that I see that I'm either good at taking out their ovaries surgically, having a radiation oncologist that's treating a pelvic cancer that's also going to be, unfortunately, delivering radiation to the ovaries. The ovaries are not resilient enough to overcome it. They absolutely need something, because otherwise they're in a radiation-induced menopause or a surgically induced menopause. They may be in their 20s or 30s. And if you can imagine, they're missing out on 25 or so years of estrogen that's protecting their heart, their brains, their bones. It's absolutely just chaotic to think I'm trying to treat something with a curative intent, but I'm condemning her to every cardiac or cerebrovascular potential morbidity, mortality as a result. But just to kind of refocus, so as far as the premenopausal levels, I think it's almost like taking a birth control tab, whereas our birth control is not the same as like what our grandmothers had. That's actually the database that I used for my PhD and my master's. And that was like when the birth control pill, you had to be married to be registered and receive it. And it was kind of a placebo-controlled trial. And it was even designed before ethics boards existed, which is wild. But those were really high dose estrogen-based contraceptives that had a high risk of having a blood clot, either in the leg or the lungs. There's still risks, of course, with everything we do, but I think we also have to think about what is the alternative for patients that actually need birth control in their lives. It's a lower risk than being pregnant, so that's food for thought. But until you're about 51, I think it's very reasonable without the sugar kind of pills that you take a daily birth control pill. It's important that if somebody has a uterus, that they are protecting the lining of their uterus, and we don't use what's called unopposed estrogen, or basically estrogen-only hormones. And the reason is we're just wanting to really protect the lining of the uterus from basically growing too much. What one of the obstetricians at Queen's used to say, estrogen is basically the lawn fertilizer and progesterone is the little lawn mower. So you don't want to over-fertilize the lawn because the jungle may be a bit dangerous.
That's a great analogy.
Yeah. So there's things like we can still use a Mirena IUD or some kind of an IUD inside the uterus that protects the lining. So even if they're wanting to potentially even just have a patch because they're averse to having tablets, that's totally fine. But it's just, they're absolutely alternatives. And then when we kind of shift gears and we're getting to kind of true around the time of menopause, then that's when we start having conversations about, okay, I think it's time to turn down the dose. Your body's not expecting that same kind of flurry of estrogen as it were before, but I'm not taking it away yet because I still want you to be able to coast, hopefully through this time, and avoiding having a flare of symptoms if this has been masking kind of the natural wane into the menopause versus looking forwards, when is it time to stop? And that's an individual conversation. And I think what we know now is, okay, we're trying to lower doses. And my preference is that we're going to continue at a dose the patient's comfortable with, that the progesterone is always being prescribed at an adequate strength. So it's overcoming the lawn kind of fertilizer idea. And then just checking in to say, are you having breaking through bleeding is never normal once you're on a steady dose. Are you having symptoms? And then in the background, are we checking in on bone health, these sorts of things? But at that point, it's just saying, okay, like, I don't want you to be on ideally hormones until you're 80 years old. I think that would be an unwise decision. But if it's kind of 5 or 10 years past the menopause and they're really attached to that and it makes them feel better, who am I to say, like, I want your quality of life to suffer because I need to feel better that you're off of these things? Go for your mammograms, get your fit or colonoscopy.
Yes.
All of these things like are available to us, and we should make them available to all of our patients. We're all eligible for them.
At least in Ontario, we are.
At least in Ontario.
I just don't understand why it's such a black box and why it appears that it is easier to ask for painkillers or antidepressants, which are brain altering. I mean, than something our body produces, estrogen, progesterone. What would you want other primary caregivers to walk away with, while you're here on this couch? Because I have community members text me, message me, or come up to me telling me they're still being discouraged or turned down.
Yes. I think both sides, some honesty with your patient and just understand what are her goals, because sometimes same thing like asking for pain or like mood things, they're trying to convey something that's very personal to that doctor. You're really wanting to understand what are they coming from? What are they wanting to see improvement in their lives? There is very little danger of basically any of these hormones. And then the effect should be pretty quick, like within a couple months, I would expect to see the desired effect. And then it's like, okay, is that symptom still there? Is it because the dose isn't correct? Or do I have to actually consider a different differential diagnosis? So is more testing warranted, a referral to a specialist, what have you? But it's absolutely fine to go ahead and order like a trial of hormones and say, oh, wow, it made you feel better, Beatrice? Awesome. Like, go us. And now we're going to carry it forward. I think it's super exciting. But other things like the North American Menopause Society has an awesome course. And so basically I wrote that exam last year and I have the textbook and I'm still climbing through it. And I go back to it often. I've got some areas that I've just bookmarked because I want to go back. And there are some things that have been either on back order because of COVID. But there are so many things. And I think it's just also realizing sometimes, okay, the tablet doesn't work. Do you want to try the patch? And various strategies there are from different perspectives. So patients that we know that the patch is better for patients that have like higher cholesterols, can potentially reduce the risk of blood clots, of course not negate it totally, but that there's some benefits. And patients who are on anything topical, if it's not working, then those are the patients who really should order the estrogen panel or like a hormone panel for, because they may not actually just be absorbing it.
Mm-hmm.
So maybe those patients actually need something by mouth to be really sure that they're actually absorbing the chemicals that they're needing, hormones being the chemically active substance, to feel better.
Mm-hmm. What about vaginal estrogen? That seems to be almost unspoken. Like, so what we have get-togethers with women, and we'll mention it.
I love it. I love it for my patients. It makes them so happy because some patients, for instance, like discomfort during sex, just general like recurrent UTIs. So many patients are told like, oh, you have a yeast infection after the menopause. Yeast before yeast after the menopause or even before menarche, someone's first period, is extraordinarily rare. My odds or my bets are more likely they have genitourinary syndrome of the menopause, basically atrophy. So the tissue loses the folds, it loses kind of the plumpness. And so these are the patients that really benefit the most from vaginal estrogen. And there are so few reasons we can't prescribe that to our patients.
On behalf of patients who are breast cancer survivors, can we address that? Because I think there's that added layer of fear with any form of hormone therapy. So Let's start with vaginal estrogen.
Yes. So these are topical estrogen products. So ones that are applied to the vulva, the vagina, have very little, and it is a very individualized kind of take up of systemic kind of absorption. There's never zero. I recognize that totally. But it is not enough to have either therapeutic effect. It's not going to help your hot flashes, that's for sure, if that's what you're suffering. And I doubt that it's ever going to be in a clinically meaningful concentration to actually affect any oncologic outcomes. Basically, my endometrial cancer patients, so patients with a cancer of the lining of the uterus, virtually all of them can have an estrogen replacement afterwards. Cat is beautiful.
He's the team mascot. He's the executive producer of this time of the month.
But there are very few reasons not to. I don't treat breast cancers myself, but these patients are commonly on anti-hormone treatments where the idea is that you're trying to get your estrogen level to essentially zero. And that has a lot of fallout on every tissue, but especially on vulvovaginal health, and not forgetting the bladder too. And I think it's just something that the patient has to have a discussion with their oncologist. We're relying on oncologists to have up-to-date information about what is safe, because I think we're doing a great job now of curing cancers. We need to think about survivorship. So there's a whole new thing with oncology called cardio-oncology, and especially realizing kind of women have been left in the dust with regards to cardiology. We present differently when we have heart attacks. Almost everything is a bit different as far as women go. Women are dismissed when they're presenting with an atypical symptom that's then a delayed recognition of a heart attack sometimes. But I think we just have to go back and say, okay, like this is not going to make your cancer return. And I think we need to do a better job of having you live well after your cancer. There's already a fear of recurrence. There's whole support groups in our cancer center for that. But we need people to kind of live their lives and hopefully not with what we call the toxicities or the residual side effects of all the treatments we've had to ask them to endure.
It's hard to believe that in 2023, we're realizing that there's entire gaps in how we care for women, whether it's cancer, menopause, you mentioning cardio-oncology as something that we've now have to look at differently. I'm amazed that there's only 6% of R&D dollars. The number may vary, but it's low. It's disproportionately low compared to health research in general. How do we change that? Where does it start? Like if we go all the way back to med school, were you even taught about menopause?
I think, and I loved Queen's Medical School. I'm very biased for it. I think that we probably had one singular lecture within our OBGYN block all about menopause. Whether it was even how to prescribe it, I'm not quite sure. But it's kind of a fading memory for me now. I think it's something that we can educate this new generation. We can overcome Women's Health Initiative by just going now and saying, yeah, we had this crazy study. There have been crazy things that happened in the past, and we've overcome them. Like in the 60s, 50s, whatever, we realized smoking is bad for us. Oh my gosh, maybe we should stop smoking. It's like, wow, let's wake up. Let's realize this together. We can overcome the WHI. We can tell medical students what are basically recipe cards for like, okay, your patient has a uterus. These are her symptoms. This is something you can try first. If this doesn't try, maybe this is the next, or at least try one thing and you've tried, and then refer to a gynecologist or somebody that has experience in being a menopause kind of provider. I think there's a load of things that we can do. As far as the funding thing, I'm not exactly sure. I think everybody always has a passion for what they do. Everyone feels that their personal area is usually pretty underfunded. But I think we can go a lot more deeply into preventative health, and then also in the aftercare. I think we put a lot of our kind of burden of finances into the treatment themselves. The one thing I'm also really passionate about is time toxicity, and just are the treatments that we're giving actually giving benefit for people's lives? If they're detracting from quality and not adding benefit, these are not the things I don't think we should be investing our time and money in. We need to recognize that probably there are some opportunities to recognize disease in early stages. I think this also applies to the menopause, and just recognizing this will be a universal experience. If we are so lucky to live as long, we are going to experience it. What is it going to be like, and how is it going to influence our future health?
So on the prevention side, which I like to think of, and you may disagree with me, but I feel sometimes like our system is a disease care system rather than a health promotion or health care system.
Yes.
So what should we be focused on the prevention side to go through menopause as best we can?
Yeah.
What would be your top 3?
Yeah. So I think this is where maybe we go back to the annual health visits, and it's more like checking in. When was your last period? Please actually track your periods, because then you're realizing, and I think this goes for anybody that has a functional uterus, where you're aware of your fertility potential. So there aren't accidental pregnancies. I feel like there's a lot of ownership we can give back to patients and empower them to say, like, yes, what I tell my patients is, you live in your body every single day. No one knows it better than you. Don't let anybody tell you that they know it better than you, because I will trust you when you come to me and say, Dr. Pokoradi, I've got a symptom. I'm going to believe you, and I'm going to ask you about it, examine you, do whatever. But I think we need to know, where are your periods at? Are they starting to space out? Like, diarrheaing symptoms is really powerful. That's one thing I remember definitely from my OBGYN medical school. It's like, yes, just actually, like, that was a classic thing for premenstrual syndrome is, oh yeah, you're moody or whatever symptoms. And then your period comes, like, oh yes, okay. But I think we can see how are things relating, to hopefully kind of understand, okay, like, I wasn't expecting it maybe so early, but it looks to me like maybe you're going into menopause prematurely. And these have really important health implications for you. And let's talk about it. I think there's just that kind of opportunity where we can use, that's almost like a really open-ended screening test. So it's not necessarily, okay, we need to do blood work, because I don't think it is. I think a lot of it is clinical, because I think probably hormones are being over-tested, and then patients are coming in, or I get calls and they say, well, these are the results. What do they mean? But I still have to say, well, like, what was the patient telling you? Because that will tell you a lot.
I think that a lot of women are so busy, and because they didn't receive education, either didn't talk about it with their mom, it's not spoken openly, they're completely missing the signs. We tend to think it's later in life. And women are spending more time educating themselves, building their careers. We've talked about this in other episodes as well, but it's worth mentioning again. Why should a younger woman, I'll use the word younger, but care about perimenopause? Because that I was blindsided. I don't want others to feel that way. So what would you tell women in their 30s?
Yeah, I'd say trust yourself. You know yourself. Your doctor has to buy into that too. And you can always ask for another referral elsewhere, and they shouldn't be taking that as an insult. I often, if somebody asks me that, it doesn't happen often with what I do, but I am totally fine with that, because I want them to feel heard. I think that's something that's so important. I think we're really commonly having symptoms desist. I think it's an awesome opportunity where we're improving quality of life. Sure, I think like I said earlier, there's very little harm with adding on like a birth control tablet, or it's like, oh, you just mentioned that. Like, have you noticed like vaginal dryness, or is sex painful? Or are you having recurrent bladder infections, or like pain when you're peeing? Like, oh, okay. Like, actually, like the doctor should then say, oh, thanks for handing me the torch. I'm going to like try and find our way out of this, and just make sure that you're kind of fully fleshing out that situation. Because sometimes it's just kind of cracking the door and you're saying, oh, look inside this room, because there's actually more things to find. There's so many opportunities, I think, where we can optimize people's health. I recognize that, it does come at a healthcare cost, But I think the fallout of kind of being ignorant to all of this and choosing to turn our faces away from it, I think that's the bigger cost. And I think it comes at the kind of confidence in doctors by women.
Dr. Pokoradi, if there are 3 things you want our audience to hear from you and remember, what would they be?
Yes. So vaginal estrogen, please use it generously for your patients. If you're suffering with any symptoms that could be related to vulvovaginal health or bladder health, ask your doctor. There's so little risk with using those medications. And if one's not working, there's others to try. There's even oral pills. There's a new one called osfemifene that's on the market now. So there's loads of things for vulvovaginal health. The second thing is to not forget about bone health and all the things we can do to optimize osteoporosis risks and management that way. Making sure that calcium, vitamin D are optimized, and ask your family doctor about when you need a bone scan. Really important things. Other screening things are so important. I'm an oncologist. I care so much. Please, the mammography, please go ahead and do it. I'm in a high-risk breast cancer screening program myself. It didn't hurt as much as I was thinking it would. Please go and do it. It's so important. It's better to find something early. That's the whole point of these screening tests. Same with the colon cancer. And I would be completely remiss if I said, please go and get your pap smear done. So important. Because sometimes someone might recognize and kind of validate your symptom that, yes, you had something going on, and yes, you were right. So please go ahead and do those. Your family doctor, your doctor should always be in your corner.
Thank you so much.
Thank you so much for having me.
Dr. Pokoradi, what makes you feel beautiful?
Getting old. Getting old. I was recently writing my GYN Oncology fellowship exam early September. And one of my favorite ways to procrastinate was actually looking into my family history. And I realized how I've already outlived so many of my ancestors. And so how lucky am I to still be here? How lucky am I to still be older than some of my patients who never got to the age I am? And so I think it's something that, as much as I fight it, and I pour a lot of money into fighting, it's just so awesome just to be able to experience, to be able to connect with patients every day, with awesome people like you who are really trying to make a difference in people's lives. Thank you for doing everything you're doing.
Thank you. It's a privilege to sit with you and to remind ourselves that we are so privileged to get older.
Yes, totally. Thank you.
I want to give a shout out to all the healthcare professionals working out there. It's hard. I know the system is overburned, and we are thankful for what you do. So today's segment is a tribute to you. I don't know if you've discovered figs yet, but if you want your workday to feel a little bit more colorful, comfortable, and stylish, just to bring a little bit of joy in that hard work you do, go get yourself some figs to brighten up your day. I don't give a figs. Oh, for fig's sake. Who the figs do you think you are? Figs off. I don't give a flying figs. Figs around and find out. For fig's sake, I got 0 figs to give. Stop figsing around, as that is pretty figsed up. What the figs? I don't give a flying fig. Zup.